We got a nice little review session today on strokes and always some good kind of pointers and tips and tricks and everything. So excited to get rolling with this today. And so we're going to jump just right into it. I'm going to keep this up so I can see if anybody else hops in here with us right now. All right, but getting started, like I said, let's just jump right into it. The whole stroke section is pretty important, right? It's one of those most kind of critical, time-sensitive situations that we have. So the other name for the stroke is that CVA, right? Cerebrovascular accident is just another name for stroke. I believe I saw something a little while back that said they may change it to cerebrovascular incident. And just saying it's not really an accident that this happened, it's just an occurrence, right? But it's still more commonly used that they use that CVA terminologies. So cerebrovascular accident. So what is it? It's a condition resulting in decrease in blood flow to the brain, right? And we're going to get into the different types, but ultimately something has happened that is resulting in not enough blood flow getting to a portion of the brain tissue. And so how this presents is going to kind of be dictated based off of where that issue is and what portion of brain isn't getting good blood flow and what that portion of the brain actually controls. Right? But very generically, again, we just don't have enough blood flow getting to a portion of the brain. And specifically, we don't have enough of that oxygen primarily getting there. Right? The brain needs three things to be happy and healthy and functioning well. One of them is obviously appropriate amount of oxygen. The other one is an appropriate amount of sugar, specifically, right? The nutrients, the sugar. And then the third is an appropriate temperature, right? So not too cold, not too hot, just right. So brain functioning heavily dependent on oxygen, sugar, and an appropriate temperature. Now we know other things can impact it, but those are kind of the initial three that the brain requires to keep functioning properly. Right, so we have two main types, ischemic and hemorrhagic. Ischemic is hands down the most common, right? About 80% is what our EMT textbook says, right? 70 to 80%, depending on which one you're reading. But we can run with 80%, right? And then when in doubt, I want you to think ischemic stroke for sure. And if there's ever any sort of like demographics types questions, the best place for you to start is by just memorizing which one is the most common, right? Before, specifically memorizing 80 and 13 and anything else is making sure that you have it memorized for which one is most common, right? Do that one first, everything else comes after that. So about 80% of strokes are ischemic. That's caused by a clot that's blocking the blood flow. So again, we said it's not enough blood is reaching a portion of the brain tissue. So in an ischemic stroke, it's because of a clot, right? So we have that clot that is actually blocking that cerebral artery and blocking that blood flow to the brain tissue past it, right? Just like we have that clot that builds up in a coronary artery, and we call it an MI. This is the same thing. It's a clot that formed or got stuck in a blood vessel in the brain, and we call it an ischemic stroke. The other one, the main two, we see the numbers don't add up to 100%, so that definitely means that something else has to be happening as well. So the other one is a hemorrhagic stroke, is 13%. Roughly, again, these are rough numbers as of a handful of years ago, but they hold pretty true, pretty regularly. So hemorrhagic strokes are about 13%, and that's a bleed, right? So a little blood vessel in the brain, instead of getting a clot that's stopping that blood flow, that blood vessel actually ruptures, and so the blood starts leaking out, starts bleeding into the brain tissue, instead of continuing down that blood vessel to perfuse that other portion of the brain tissue. And so hemorrhagic is about 13. Some of the other ones would be like a vasospasm, right? It's where a blood vessel actually spasms and constricts so much that it's reducing and cutting off that blood flow. And so that's where you kind of get 80% and 13%, that's 93%. So we have another 7% of things that can happen that they would call it a stroke. So probably one of the other ones that would come into play is a vasospasm, right? So we're constricting that blood vessel in the brain so significantly, right? That pipe is so small that we're not able to get the blood flow sufficiently to that tissue past it. But we're just going to really hone in on the main two, ischemic and hemorrhagic. So on the ischemic stroke, we said it's a clot, right? The clot that is blocking that blood flow in the brain. And so there's really two ways that clot can get there. One of them is if we have this blood vessel in the brain, that clot can just build up on its own right there in that spot. And once it builds up so significantly, it's reducing, right? It's just closing off that pipe until eventually it'll clot over entirely, or at least restrict it so much that, again, we're not getting good blood flow past it, right? So when you have a clot that just forms in one space and it just stays there, then we call that a thrombosis or a thrombus, right? So a clot forms at the site of the blockage. Very much both of these, by the fact that there's a clot buildup, is very commonly tied to atherosclerosis. I'll write that on here, atherosclerosis. Okay. That's that plaque buildup in our blood vessels. And so we get that plaque that builds up, it kind of builds up on the inside lining of our blood vessels throughout our whole body. That's kind of generically what they start talking about, cardiovascular disease. Right? And one of the more common ones is that plaque buildup. And that plaque buildup is things like cholesterol, poor diet, lack of exercise, right? We start to get the plaque that builds up. And that's really why these ischemic strokes are so common compared to hemorrhagic strokes, just because of how common the cardiovascular disease is and the high cholesterol levels that people have. Those are just very, very common disease processes that are out there. And so if we're going to have a stroke, it's much more likely that we're going to have a stroke because we have that poor cardiovascular system and we have all this plaque building up. So that's that atherosclerosis, is the plaque building up. Most commonly we talk about that, and just because we probably talk about it a little bit more often than strokes, are those heart attacks, those myocardial infarctions, right, where we have that clot that forms in that coronary artery. That clot that forms is, again, just a continuation of that plaque that has been building up. And once it builds up so much and it starts slowing down that blood flow moving through, then it starts to back up a little bit, starts to form that fibrin mesh network that actually forms the structure of a clot. Excuse me. So the other one, so thrombosis, again, it forms right there. Embolus is the exact same process, but that clot formed somewhere else and then broke loose in the body, right? And then that clot now travels around until it gets stuck somewhere, right? So you've heard the terms like deep vein thrombosis, right? You get a DVT, that's a clot that forms in your leg. And then if it breaks loose, right, now that clot's floating around in these blood vessels. And once it reaches a smaller blood vessel, it'll eventually get stuck, right? So a common place that we get the embolus, if that's where it caused it with the stroke, is plaque that's building up in our carotid arteries. And if any of that plaque breaks loose, it's going to go straight upstairs, right? And so that plaque, because of that poor overall health, right, lack of exercise and poor nutrition and everything, that plaque is building up in our vasculature. Then we get some plaque that builds up in our coronary or our carotid arteries. If that breaks loose, again, it's going to go straight up with the rest of the blood flow. And eventually, however much that plaque is there, eventually it's going to get stuck somewhere. Right? It's going to reach a tiny little blood vessel in the brain, and it's going to block off blood flow. Another one that can happen is inside of the heart, right, where the blood is actually circulating through and being pumped through, is you can get a clot that forms in there, and then when that heart contracts, right, it fires that clot up into the brain. Right? So it's a common one if you've ever heard of the arrhythmia atrial fibrillation, right, AFib. You see some commercials for medications and stuff like that for AFib, probably more commonly than any other heart rhythm problem. But that AFib, there's a very big stroke risk, and it's because there's a very big clot risk of blood kind of clotting inside the heart. And then that left ventricle, when it contracts and pumps blood out to the rest of the body, right, it fires that clot straight up into our cerebral arteries, right? It goes out the aorta and then up the carotid arteries and up into the brain until it, again, reaches a clot, or reaches a small enough blood vessel, a small enough pipe that it cuts off that circulation of blood flow past it, right? So a slight kind of definitional difference that would be good to understand is the thrombus versus an embolus. Thrombus, that clot, again, it just forms right there, and now it's cutting off blood flow. Embolus, that clot formed somewhere else, broke loose, and then got stuck in that blood vessel inside the brain. All right, the other one is a hemorrhagic stroke. And hemorrhage, we said, is a bleed inside the brain. And this is where we actually get a blood vessel inside the brain, for whatever reason, has ruptured. Right? And once that blood vessel ruptures, again, now instead of that blood continuing down the blood vessel to the portion of the heart that it's trying to perfuse, now it's leaking out of that ruptured blood vessel just into the brain tissue. Right? So it's no longer in the pipes, it's no longer in the blood vessels being delivered, it's leaking out into the tissue. And that's actually what it looks like on a CT scan, right? Not that you need to be able to recognize off the CT scan or anything like that, but those kind of big white spots, right? And the CT scan just looks at layers, right? So it's looking at a layer, a layer, a layer, a layer, a layer, right? And so they're just kind of doing little cross sections of the body, and specifically the head in this one. So this is just further down, the head as the CT scanner is evaluating it. So those big white spots show up. That's actually blood filling up inside the space inside the brain, right? And that's what they go looking for to help determine if it's a hemorrhagic stroke. So typically the cause is an aneurysm, right? A swelling and weakening, and eventually a rupture of that blood vessel. Now it could be a defect, right? It could be something that they were born with, they've had all their life, they just had no idea because they've never had any issues, never had any complaints. Or it's usually secondary to a disease process like chronic uncontrolled hypertension, right? So just that constant high blood pressure, right? Whereas the blood pressure is just higher and higher. I mean, blood pressure is a measurement of the pressure of that blood pressing against our artery wall, right? So if it's constant high blood pressure, it's just constantly putting too much pressure on that blood vessel wall, and that blood vessel can start to weaken and weaken and weaken. And so if we were looking at a blood vessel, eventually what would happen is we would start to see it ballooning out a little bit, right? And if the problem keeps getting worse, right, it's just going to keep ballooning out larger and larger and larger until eventually what happens is it ruptures, right? That tissue of the wall of the blood vessel just gets weakened so much that eventually it just tears through the wall, and now that bleeding is happening out into that tissue space. So there's 3 layers, right? Just with a lot of things, there's 3 layers of the tissue of our blood vessel, right? Just like the meninges, right? The membrane layers wrapping around the brain and spinal cord, there's 3 layers. Right? There's 3 layers of their heart, right? Epicardium, myocardium, endocardium. There's 3 layers of a blood vessel, right? And it just slowly, because of this weakening, typically, again, because of that just constant high blood pressure, that chronic hypertension, it just tears through that first layer, then tears through the second layer, and eventually tears through that third outer layer. And again, that bleeding now is just progressing out into the tissue. So again, most commonly, that chronic uncontrolled hypertension is a big one for the hemorrhagic stroke. The ischemic stroke, again, more so that clot building up, that plaque formation that's building up inside our blood vessels restricts the flow. Hemorrhagic strokes, more so the chronic hypertension. And again, it results in a weakening of that blood vessel wall. We call that weakening an aneurysm. And then eventually, if we don't intervene in some capacity, if they don't go to the hospital and get it evaluated and treated, eventually that blood vessel is going to rupture, right? And it's going to leak out into that tissue. So the common, the signs and symptoms, really associated with a stroke are very widely variable, right? There's just a lot of potential for how it can present, and if it's an ischemic versus a hemorrhagic stroke. But I mean, we talk about a couple main ones that we'll hit on. But again, it's dependent on what is causing the problem and what portion of the brain was restricted of that blood flow and isn't functioning properly. So is blood flow not reaching that portion of the brain that is really responsible for speech? Then you're going to see speech signs and issues. Is there a clot blocking the portion of the brain that's very big on muscle coordination and gross and fine motor skills? Right? Well, if that's not getting enough blood flow, those are going to be some of the signs and symptoms that you see. Right? If it's cutting off blood flow to a lot of the brain, then we may just see them, be completely unresponsive, right, or significantly altered or confused. Right? So a lot of different presentations, again, just depending on where in the brain the issue is and what, again, that portion of the brain was responsible for. So maybe you see that poor muscle coordination, right? We'll talk about it. Usually on one side of the body is how it'll show up. They could be altered, confused, unresponsive. Speech problems, and there's some words and some terms that you may see. One of them is aphasia, right? Just separating out the A from the phasia. Phasia is referencing speaking or speech. And then if you put an A at the front of it, it means no or not. Right? So aphasia, they're not speaking at all. Right? They're not able to make any sounds. Right? And sometimes you'll actually see that. I remember a call that I had one time, a stroke patient, as an elderly female, and she was alert. She was looking around the room. She was completely unable to speak. Right? Not even, moans or groans or anything. It was just complete silence. She had no ability to speak. And you could tell, really, just by that look in her eyes, you could tell that she was alert and knew what was going on, but couldn't speak. Right? And prior to the stroke that she was having, she was able to speak and everything. It's a big thing to find out, is what's baseline, what's normal for the patient. Right? So she was normally alert and oriented ×4, could talk and everything. And she was having this, ended up being a stroke. And the stroke that she was having was cutting off, amongst other things, it was cutting off blood flow to that portion of the brain that's responsible for our ability to speak, right, and produce the sounds. And so she was looking at us, and you could tell that she was conscious, and, it wasn't just kind of that glazed off look into the distance. She was completely alert, looking around, but unable to speak. Right? So that's aphasia, right? Aphasia. Another one that you may see is dysarthria. Dysarthria. The DYS is difficulty, and arthria is articulating. So difficulty articulating their speech. So that's slurring their speech. Right? They're talking to you, they're saying words, but they're slurring the words, right? That's dysarthria. DYS is difficulty, arthria is articulation. So difficulty articulating their speech. So they are talking to you. They may be oriented completely, right? They may answer all of our person, place, time, and events questions just fine, just the answers are slurred, and that's not normal for them. So you may see that thrown in there as kind of a medical terminology thing. So dysarthria is difficulty with articulating their speech. The DYS, again, difficulty, if you think about dyspnea, and difficulty breathing, you see that prefix of DYS quite a lot. Weakness and numbness, confusion, we said, a headache, a very sudden onset, very severe headache is one of those kind of classic symptoms that they'll give you that's going to kind of push us more towards the hemorrhagic stroke as opposed to an ischemic stroke. Right? So that very sudden onset, very severe headache. Sometimes they'll say like a gunshot went off in my head or the worst headache of my life. Those are some of the descriptors that sneak their way into test questions. I promise you'll see some of those. So that sudden onset, severe headache, is actually the rupturing of that aneurysm, right? So it's a very sudden rupture of that aneurysm. It's a hemorrhagic stroke, right? There's a bleed going on inside their head. Like I said, there's a lot more. It all depends on what, where that issue is inside the brain. Right? They could have vision problems, blurred vision, double vision, loss of vision. Again, it's very heavily just dependent on what portion of the brain, again, is not getting good blood flow and what that portion of the brain is actually responsible for. So what we evaluate on is the FAST score, right, or Cincinnati Pre-Hospital Stroke Scale. It's most commonly is the 3-category of facial droop, arm drift, and speech issues is the main 3 that we're looking at. So FAST is the acronym. Facial droop is just, if you look at them, one side of their face droops down, it's weaker. Sometimes it's easier to evaluate if you have them smile, right? And they smile and the muscles engage on one side into the smile, but the other side kind of slumps down, right? It's drooping down. It's that one-sided issues with the face, with the muscle control of the face is a potentially more common sign of some strokes. Another one is arm drift, and one of the important aspects of arm drift is making sure that you're double checking in your textbook and everything of how exactly are you supposed to do it. So what you do is you have the patient close their eyes and they go arms up, palms up. Right? It engages different pieces of the nervous system if your arms are supinating versus pronating. Right? So arms up, palms up is how you do it with their eyes closed. Right? So have them, again, close their eyes. Sometimes you can raise their arms up, right? And then what you see is you'll see one side will droop down, potentially, right? It's what is going to help us support that diagnosis of a stroke, or that differential diagnosis, or the field impression of a stroke, right? So that one of the arms drifts down, right? So they have weakness on one side of the body, right? Again, if you do both arms up, right? It's different. Most people are able to do that. If their eyes are open, sometimes what will happen is that if the person sees one of the arms kind of drop, they, kind of by willpower and strength and muscle and conscious control, try to do that. So it's better, again, you have their eyes closed and they won't even realize it to the extent as if they were seeing their hand drop down. Right? So eyes closed, arms up, palms up, and we're looking for that one of those arms to drift down. And then speech, we kind of just talked about that one a little bit. Slurred speech or absent speech or confusion, right? So any sort of speech issue, right? And again, absent speech is a positive speech issue sign. So those are the main 3. If they present with all 3 of those, there's a very high degree of likelihood that they are in fact having a stroke. Now, patients can have these things and it ends up being another problem. We'll talk about some of the other things that can present like a stroke. But if we're thinking it's a neuro problem, we're thinking maybe this is a stroke, and we have the patient smile and we see the facial droop, we close their eyes, and arms up, palms up, and one of those arms drifts down. And in that conversation with the patient, you determine that they're confused, right? They're saying the wrong words that don't make sense. They're slurring their speech, or they're not able to speak. Right? Any of those types of things we can say is a positive speech. So we get 1, 2, 3, and we're very likely that our patient is in fact having a stroke. And then the T, just to round out the acronym, is the time that they were last seen normal. Right? A lot of medical decisions in the hospital is going to get based on what time did these symptoms start. Right? So some hospitals, for the longest time, there's been some changes, but for the longest time, some of the medications that they would try in the hospital, they would only try if these symptoms had started within the last 3 hours. And 3 hours was a very hard and fast rule that we all had to run by, of exactly when, like to the minute, as much as possible, exactly when did this start? Because everything is going to be based off of that time for that 3 hour window. Now, a lot of hospitals and a lot of research studies are happening. They're trying 4-hour windows and 6-hour windows, right? They're pushing it a little bit. So there has been some give a little bit, but 3 hours was just a common number that we ran with, that if the stroke had started or if these symptoms had started more than 3 hours ago, then some of those medications in the hospital were now contraindicated. They wouldn't use them for the patient. And the thought was just on kind of a risk-benefit side of things. They would say beyond 3 hours, you know, the risks are starting to outweigh the potential benefits that we could get, right? Because if it was a clot, they would give those medications that would break up and dissolve that clot. What would end up happening would be that increased risk of actually causing bleeding somewhere inside the body because we were dissolving all the clots. So that time lasting normal is still very, very important. Is we have to base, we have to get that as closely as possible to it so that we can tell the hospital and tell the doctors about it. If the last time anybody saw them normal was dinner yesterday, then we say, okay, what time were you done with dinner yesterday? 7 p.m.? Okay, it's 10:30 a.m. So, you know, that's been however many hours, right? So it's when they were last seen normal, right? If they woke up with the symptoms, so okay, when were they last seen normal last night before bed, right? We kind of go back to whenever that last normal was. Ideally is, you know, that patient had been interacting and talking to their family, and then boom, right, real suddenly, right, they started presenting with some of these symptoms. And family members recognize it, they freak out, they call 911. And now we say, okay, we can track what time did you call 911 and when did it start before you called? They say, oh, I saw it, and then I went and got my phone and called 911. It's like, perfect. So the 911 call was 10:27 a.m. So 10:27 a.m. is our symptom onset time, and that's the time that everything will get based off of in the hospital. So time lasting normal is very critical. Okay. The other aspect of time is the whole time is tissue, right? Time is tissue determination. So brain tissue is brain and the heart is the most sensitive tissue inside the entire body to poor perfusion and hypoxia. So without oxygen, brain tissue, you get irreversible brain tissue death within 10 minutes of not enough oxygen, right? That's how sensitive it is, right? Within a few minutes, they'll start to get altered and confused, right? It progresses really quickly if that brain tissue doesn't have good oxygen. Same thing, the heart, if it doesn't have good oxygen, within a minute or two, you start to get a lot of irritability in the heart. And we worry about it going into one of those lethal arrhythmias like VTAC or VFib and the person going into cardiac arrest. And so the brain, very, very sensitive to poor oxygen levels. And so that's why we, as soon as we recognize it, we really need to be thinking rapid transport, and we got to get them to the hospital as quickly as possible. And we call the hospital, let them know we've got a stroke patient coming in, and they'll get everything ready so that we bring them into the hospital and they just roll them right into the CT scanner, which is what they need at the hospital to confirm what's actually going on up there. All right, so our recognition is that FAST scale. There's some other scales out there. You can take a look in your books, like the Los Angeles pre-hospital stroke scale. They just have a lot more criteria, questions to ask, and things to take a look at. And the more of those you answer a certain way, just the more likely it is that they're actually having a stroke. But the most common one that we all emphasize and talk about and probably get tested on is just going to be that kind of basic FAST scale of the facial droop, the arm drift, the slurred speech, and then FAS isn't a good acronym, FAS. So we added the T to just remind ourselves that time is critical and to find out exactly when those symptoms started. Right, so again, in the hospital, right, they kind of do some of those basic things that we do, but then the CT scanner is the big one. And the CT scanner is what they need to determine, is there a bleed going on in the head and it's a hemorrhagic stroke? Or is there no bleed, which is telling us probably ischemic stroke? Right? So the first thing they have to do is rule out the bleed rule out the hemorrhagic stroke, and then they'll kind of take their next steps from there. And the other aspect is kind of ruling out other things that could look like a stroke, right? So you can have hypoglycemic patients that have weakness, that are confused, that have slurred speech, right? And it looks just like a stroke, and then you check that blood sugar, and the blood sugar is low, right? Now it tells us, not a stroke, this is a sugar problem. Let's treat that sugar, and then see how their symptoms resolve, right? See how they respond to that sugar, right? Alcohol, drugs, right? You can have slurred speech, confusion, altered, and a lot of those similar signs and symptoms as well. So we got to figure out, like, hey, is there any sort of substance that they took, any sort of exposure that might have happened, right? Our game is really ruling out other things that we could do something about, right? The brain is very sensitive, like we said back at the beginning. The brain is very sensitive to oxygen, sugar, and temperature, right? So we're going to get our pulse oximetry on and make sure that oxygen isn't an issue, right? We got to make sure that we have them at least 94%, right? And the upper 90s is great. So make sure that oxygen isn't the problem. Check that blood sugar, make sure sugar's not the problem. And then hopefully there's something that would kind of clue us into if we thought this was a hypo or a hyperthermia situation, like an environmental thing, or we're evaluating this patient and they're, you know, walking around outside in the snow, like, okay, maybe it's cold temperature is what's actually causing their issue. Right? So most of our stuff initially is just ruling out things that we could do about it. Right? If we're evaluating them and we figure out that they're hypoxic, let's treat the hypoxia and see if they respond. Or we check the sugar, sugar's low, let's treat the sugar, see how they respond. Temperature, they're too cold, let's warm them up, let's see how they respond. Right? Are there drugs? Like, do we think it's a narcotic thing? And we're going to try that naloxone, the Narcan, to reverse that narcotic overdose. Let's see how they respond. Right? Once we kind of check off all these boxes and say they're not hypotensive, they're not hypoxic, they're not low blood sugar, they're not this, they're not this, they're not this. Okay, I think it's still stroke. I think it's a stroke. Right? We've ruled out all these other things, so I'm going to say it's a stroke. Right? And that's really the same thing that the hospitals do. They just have more tests and more things that they can rule out. They can get blood work. They can see if electrolytes are a problem. They can do the CT scanner, see if something else was actually going on. Right? So they just have a lot more tests, and all those tests are just saying, it's not this, it's not this, it's not this. Oh, that's a noteworthy finding. There it is. Right? And that's how they work towards that diagnosis of what's going on. So treatment for us is, first and foremost, just recognizing that it's a stroke, right? Or that it's a potential stroke, right? That recognition is critical, right? If we're really delaying transport because we're doing this evaluation, we're asking other stuff, and we just never pick up on the idea that it's a stroke, then all we're doing is delaying that definitive care that they need at the hospital. So it really is, recognition is the name of the game, right? You know, it's not the highest priority. I mean, it kind of is, right? The BSI scene safety stuff is always there. Airway, you know, before breathing and circulation is always there. But you really, you know, the earlier we can recognize that this is what's going on, means the earlier we can get them to the hospital and they can get the exact treatment that they need to deal with that stroke, so that hopefully we can correct that problem, restore good blood flow to that brain tissue, and the person goes back to normal, right? That's best case scenario for this entire thing. Otherwise, it's ABC management like normal, right? And it depends on how our patient's presenting. Is it that stroke patient, but they're fully unresponsive, and we need to open their airway, insert an OPA, and assist ventilations because they're not breathing well, or maybe they're not breathing at all? Are they alert and talking to us, which tells us that their airway is protected and clear, but they are a little bit confused and you know, a little bit slurred speech? All right, maybe we're going to put them on a non-rebreather mask because their pulse oximetry is, you know, 91%. So let's put them on high flow oxygen. Right? So those determinations are the normal determinations for us, right? When we need to assist ventilations, we'll assist ventilations. When we just need supplemental high flow oxygen, we'll do a non-rebreather. So the ABC management decisions are no different than they always are. we're always just making those same determinations of if we need to intervene to assist somebody with their breathing or their circulation or anything like that. Shock treatment has got to always be considered, right? ABC management and shock treatment. Right? They kind of, on the National Registry Patient Assessment Skill Sheet, they kind of slide that shock treatment into the circulation section. And so ABCs and shock treatment, and like we said, rapid transporting, right? Not delaying anything unnecessarily and just getting them to the hospital in as timely a manner as possible, right? We can ask the rest of our questions en route, potentially. We can do our physical exam en route, potentially. We can do our reassessment en route. We can do a lot of that stuff en routes. We just have to recognize that we think that this patient's having a stroke, and then we have to manage our ABCs how we normally would and transport them. In hospital, and I kind of kept referencing those medications that they'll take. You'll hear terms like clot buster drugs, right? Obviously, if they're saying it's a clot buster drug, the issue is there's a clot. And so since we have that clot, we need to get rid of that clot. And so the actual class of medications are thrombolytics, right? So thrombo, obviously referencing that thrombosis or the thrombus, that's that clot that formed, right? So that's the thrombosis. The lytic or lysis, and sometimes you'll see that L-Y-S-I-S, but anytime you see that at the end of the word, it's a breakdown or a destruction of or blocking, right? So a thrombolytic is a medication that breaks down or destroys clots, right? Sometimes instead of thrombolytic, you'll see them say fibrinolytic, okay? Just breaking down or destroying fibrin, right? And fibrin, again, is kind of the mesh scaffolding network that is at the core of a clot forming and being able to continue building, is a development and a progression of the fibrin actually inside the clot. Right? So a thrombolytic or a fibrinolytic, both are breaking down and destroying that clot that's blocking that blood flow to the brain. And so if that clot breaks down, goes away, now blood flow is immediately going to go back to that tissue. Right? Blood flow is immediately going to be restored, and hopefully that tissue was not so severely cut off from oxygen that that tissue is now dead. Right? Hopefully it was just a little bit injured, a little bit hypoxic, and now that we have good blood flow going back to it, we're able to restore good circulation and good functioning to that brain tissue. And then again, the brain tissue, whatever functions that controlled, hopefully those symptoms will resolve for us. And so those was fibrinolytics or thrombolytics. Those are for our ischemic strokes. Excuse me. On the hemorrhagic stroke, right, a little bit, what they do is they kind of monitor the patient, and they'll see, you know, how are their symptoms doing? How's their body responding to this little bleed inside the head? Maybe they monitor it and they see that the body is kind of clotting itself over and trying to heal itself, and they'll just allow that to continue. If it doesn't, or if it's a particularly large bleed, then they will kind of move over towards the consideration for a surgical intervention. So a little bit different determinants based off of whether they think that there's a clot in there, or on that CT scan they find out that it's a bleed that's in there. Right? Different treatments for those two ones. I skipped over a part that I wanted to make sure that I mentioned, is the weakness on one side of the body, right? Just as a reminder, remember the weakness, if they're weak on the right side of the body, then that stroke is happening on the left side of their brain. If the weakness is on the left side of the body, the stroke is happening on the right side of the brain. So it's always opposite, right? And sometimes, not too often, but sometimes they'll say contralateral weakness. Contralateral weakness. Lateral is the side. If you think medial is to the middle, lateral is to the side, and then contra is opposite. Right? So like a medication has a contraindication, right? It's a time that we're not going to do it. Right? It's the opposite. So contralaterals meaning the opposite side. So if there's a weak or a stroke happening on the right side of the brain, you get contralateral weakness on the left side of the body. right? And the way that's actually working is if you took a look at the spinal cord and you cut the spinal cord, you kind of see an X that actually forms in there. And what happens is those motor nerves and the sensory nerves that are kind of running along the spinal cord, the motor nerves exit out the spinal cord on the opposite side. They crisscross. Right? So the right side of the brain and the left side of the brain, right? Those motor nerves crisscross and come out the opposite side. Right? So whatever side the weakness is on, you can say, I know what side the stroke is on. And the stroke is on the opposite side of the brain from the weakness. So it's one of the other pieces of it, right? If you see that weakness, paralysis, altered sensation on one side of the body, the stroke is occurring on the opposite side of the brain. So that's one of the big things that can help us, or a common question type thing that would come up potentially. All right, so I always like doing a couple questions. I got two today. Just going to, again, highlight some good kind of test taking tips and everything. So let's go through this question. It says, your 68-year-old patient is confused and slurring their speech. His wife states it started suddenly 30 minutes ago, and he has a history of diabetes. His vitals are blood pressure 136/90, heart rate of 88, respirations of 16 non-labored, SpO2 of 92%, blood glucose of 82, and skin is warm and dry. Based on this presentation, you should suspect what? And we can get this out of the way. First off, so if you want, we can, in the little chat box, you can jump in there if you want, and I'll kind of go through my rationale and ways that you could change this question and get different answers. But the options are, we think it's a hypoglycemic emergency. We think it's diabetic ketoacidosis. We think they're having an ischemic stroke, or we think that they have a brain tumor. And working through these, I mean, obviously we know we're reviewing strokes today, so there's a high degree of likelihood that it's a stroke answer. But if we weren't reviewing stroke today, if this was on, your class final exam or national registry or something like that, we would have to be able to work through why we think it's one answer and why we don't think it's the other answers. Right? One of my favorite tips and recommendations for people is to say, instead of I think C is the right answer, is to flip it around and say A is wrong because of this, B is wrong because of that, D is wrong because of this, right? If you can, with a high degree of certainty and confidence, say this answer is wrong because of this reason and provide that rationale, then you can just rule out all the other answers and get your correct answer that way. So sometimes if you're kind of stuck on trying to figure out which one is correct, maybe mentally flip it around and say this one is wrong because of this reason. Right? So we're going to go through it, and I appreciate you guys jumping in and choosing C. That's obviously going to be our correct answer. Right? So one of the ones to think about, we've got a confused patient, slurring their speech, history of diabetes. Definitely sounds like it could be diabetes. Right? But A is wrong because we have a blood sugar of 80 to 82. Okay? And most books and everything will tell you a normal blood sugar is 80 to 120. Right? So 82 is not hypoglycemic, so it's not A. A DKA is a high blood sugar problem, so same rationale. We don't have a high blood sugar, so it's not that answer. Another one that you can think about, you say, well, diabetic ketoacidosis, they do usually have warm and dry skin because they're dehydrated as well. But maybe you know your endocrine stuff well and say diabetic ketoacidosis presents with those Kussmaul respirations. Right? Kussmaul respirations. Now, Kussmaul respirations are very deep, very rapid breathing. Right? So we have a respiratory rate of 16. That's not fast. That's still a normal respiratory rate. Okay? So if we took this same question, gave them a blood sugar of 400 and a respiratory rate that said 30 and deep, well, then diabetic ketoacidosis would be a phenomenal answer, right? Or take all this information, give us a blood sugar of 50, and hypoglycemia usually has cool, clammy skin. Right? So if we changed our skin signs and our blood sugar to low, we could get A as the right answer. And I really recommend doing this type of stuff when you have practice tests or practice problems, or I post them every once in a while, some questions of the day on my social media stuff, and kind of give you that opportunity to work through just more questions more often. So if you do that, beyond just taking, here's my one question and I got the answer correct, is look at it and say, what things would have to change for A to be the right answer, for B to be the right answer, for D to be the right answer. And in a way, you can almost take one question and create 3 other test questions. And now you've got 3 test questions, 4 test questions that can really help you work on choosing between a particular question or a particular answer. So ischemic stroke fits very well for this. And then the other one is brain tumor. And the thing behind the brain tumor progression is a brain tumor doesn't just show up 30 minutes ago, right? We don't have a sudden onset of symptoms from it, right? Usually what they'll say for something like a tumor progression is maybe they've been complaining of a headache and some confusion for a few months, right? It's been building up and causing issues for a few months, right? Maybe they've just had this lingering little headache for a few months and they haven't gone in and get it checked out, right? Hypoglycemia doesn't develop over months, right? It's an acute thing. Diabetic ketoacidosis takes a little while, right? I think we're going to do diabetes next week, right? It takes a little while, but it takes a little while in terms of like a couple days. So if it's at a few months, all right, it's not our DKA. A stroke doesn't develop over months, right? That's another very acute thing. So that brain tumor, that would be one if we change, we've had some confusion and slurring speech, and it started 3 months ago, right? Then that would help maybe kind of push us towards D as opposed to any of the other ones. So since it started suddenly 30 minutes ago, we'd say this didn't just happen 30 minutes ago, right? They didn't develop that brain tumor in the last 30 minutes, right? So if you weren't able to kind of determine it otherwise, like I said, that's an exercise that I love to do, which is saying, okay, tell me why this answer is wrong, right? Tell me why this answer is wrong. Sell me on it, right? And that type of thing goes so far towards that critical thinking aspect of National Registry of this one's wrong because of that, this one's wrong because of this one's wrong because of that, therefore this one is the correct answer. And certainly when you get it down to 2 possibilities, then you got to figure out, all right, what up here in my question is telling me that it's not this one, right? I've got it down to 2 answers, right? 2 I ruled out very quickly. It's definitely not those 2. So now I'm kind of tossing up between these 2 answers, right? Something in there, something in that question will push it to one versus the other. And so you got to think through, okay, well, how would this one present? How would this one present? What is different about these 2 in terms of those signs and symptoms? And that'll get you your answer there. All right, let's do one more. Like I said, I only got 2 questions on here today. Your patient was presenting with facial droop, unilateral weakness of the body, and slurred speech. During transport, the patient's symptoms resolved. This is known as what? So we've got a cerebrovascular accident, a transient ischemic attack, presbycusis, or nystagmus. Right? So 3 of those 4 answers we didn't actually discuss. See, based off of background knowledge, wherever you're at in programs, if you remember, right, it looks completely like a stroke, but the symptoms went away. And that's the key aspect of this one. Right? During transport, the symptoms went away. They resolved. So our cerebrovascular accident, we said that's our CVA. That's the other name for a stroke. Certainly facial droop, weakness on one side of the body and slurred speech sounds completely like a stroke. But a stroke that spontaneously resolves and goes away very quickly. We have a transient ischemic attack, or a TIA. A lot of times you'll hear people talk about that as a mini stroke. Right? Mini stroke. Presbycusis. Don't see that word too often. Right? Don't just choose answers because you don't recognize an answer. That's never usually a good recommendation. Presbycusis is a fancy name for a hearing loss, right? One type of a hearing loss. And nystagmus is eyes twitching, right? We'll say eyes twitching. Right? Typically side to side, right? Typically side to side, but it could be up and down. But if you just look at their eyes and their eyes are just twitching side to side, that's nystagmus. Presbycusis is a neural problem for causing hearing loss. A full-blown stroke, or the transient ischemic stroke, what a lot of people call the mini stroke. Right? And yeah, you guys got it there with that one. So the B is definitely it, right? It is a stroke, right? It walks like a duck, talks like a duck. It's a duck, right? So it's a stroke, right? We've restricted blood flow to a portion of the brain tissue, and it manifests with all of our normal stroke signs and symptoms: facial droop, one-sided weakness on the body, and slurred speech. But it resolves on its own, right? It wasn't medications at the hospital. It wasn't some sort of other intervention, right? It resolved on its own. And so a person showing stroke symptoms, and they've been playing around with the numbers a little bit on what's that time frame for if it resolves on its own. We'll call it a TIA instead of a stroke. For the longest time, they were running with if it resolves within 24 hours, just on its own, it resolves, and the body deals with the problem on its own. Then they say it's a transient ischemic attack, which they say is like that precursor to the big stroke, right? It's letting us know that this person is having some sort of issue, right? Some sort of plaque buildup, clot progression that's forming, right? And a piece of that plaque broke loose and blocked off that blood flow, right? Caused those stroke symptoms, but it was small enough that the body was able to deal with it, right? So we know the body has its own natural ability to form clots, which means the body also has its own natural ability to dissolve clots when it doesn't need them, right? So if it's really, really, really small, right, the body can potentially deal with it, right? So they get this little bit of plaque that breaks loose, it goes into a teeny little blood vessel in the brain and forms kind of that little clot and causes our stroke symptoms. But then the body on its own is able to dissolve that clot and restore the perfusion to that brain tissue, and those stroke symptoms go away. And what that tells us is they've got enough plaque buildup and things happening, you know, in probably their carotids again, that we're really worried about that likelihood that they have a very big stroke that causes a lot of issues, and it's big that the body can't deal with it and resolve it on its own. Right? So those stroke symptoms that resolve on their own is the TIA, transient ischemic attack, or that little mini stroke, right? Mini stroke. So again, double check in your books what time frames they're operating on, just for, you know, kind of the answers specific to your course. Most of the time, it was stroke symptoms that would resolve within 24 hours was the number. I did see, it might have been in our paramedic textbook or something else I was reading that said 72 hours. But most often, it was the stroke symptoms resolved within 24 hours was the big difference between those two. All right, so there's a couple questions for today. My next section, I'm getting more organized with all this, and I'm having fun, so I hope you guys are enjoying it too. But my next section, I'm gonna do Tuesday next week. I'm in Arizona, so we're on Pacific time. So 2 p.m. Pacific time on May 5th, Tuesday, May 5th. Cinco de Mayo, right? That's 5 p.m. Eastern, right? It's a 3-hour time zone shift. So just double check it, make sure you get the right one. I'm also starting to do, I'm going to do some email announcement reminders. If you signed up on my website to come to these, which I hope you did, that's where I upload all of the past videos as well, so that you can go back and rewatch these anytime you want. I've been putting them on YouTube as well, just kind of open to the public. I don't know if I'm going to continue doing that or if I'm just going to funnel it all through my website, but that's where you can definitely find them, probably on YouTube as well. But Tuesday next week at 2 p.m. Pacific time, and we're going to do all that diabetes stuff. So we're really going to dive into what's going on, right, when we have that hypoglycemia, and then when the blood sugar goes too high, and that DKA, that ketoacidosis presentation that we were talking about, a little bit that can look like a stroke. It's just going to be another big ticket issue that will be there. Right. So study habit builder. Again, I like to always kind of leave you guys with again something tangible. It's very weird. Most instructors and people won't say it, but sometimes people study too much. Right. I say that with a huge grain of salt because some people definitely need to study more. Right. So don't misunderstand me. Make sure you kind of do that self-audit. You probably know if you need to study more or study less. But take a break. Right? Regardless of how much you're studying, take a break. You got to give your brain that little mental rest button, right? So take a break, right? So I like saying 50-10, right? Work real hard for 50 minutes and take a 10-minute break, right? And a true break, right? Get up, stretch, right? Close your eyes, do some meditation, right? Set your intention. If you're going to keep studying, set some intention for what that next little study session of 50 minutes is going to be. Right, but you got to take a little mental break. Closing your eyes is good, right? Because you're sitting there just staring at all the pictures in the textbook, all the words, or studying on a computer screen. So it becomes a big kind of fatigue part for the brain, just that constant visual stimulus. So a break, right? A good quality break to give your brain that reset option or that reset kind of ability and the benefits of it. A good break is not then picking it up and going to social media or playing games on your phone, and it's just more stimulus and more stuff that your brain has to process and deal with it. Right? A good break would really be getting up, right? If you've been sitting there for an hour, studying in your textbook, right? Get up, stretch, move your legs a little bit, get that blood moving again, right? Kind of restore that energy in your body, right? Drink some water, all those things, but close your eyes as well, right? And say, okay, my next 50-minute block, I'm here in the textbook. I'm going to study just this next section of the book, right? Of this chapter, right? Again, I really recommend breaking it down into smaller little chunks, right? And say, okay, I'm studying from my neurologic emergencies chapter, but I'm just in this 50-minute block, I'm just going to study the stroke part of this chapter. And then I'm going to take that 10-minute break. And then at the end of the 10 minutes, I'm going to say, okay, my next intention, my next little section, I'm just going to study the seizure section for the next 50 minutes. Right? Too often what happens is people sit down, and I have students, on a weekly basis, I have students that tell me they're struggling, and I sit down with them and I talk to them, and I find out, I tell them, I'm like, well, what's your study time look like? What's your study time look like? And they say, you know what? I'm not working this school. This is my full-time focus right now. I'm studying 7 hours a day. And I tell them, you're probably getting like an hour and a half of actual quality study time. Right? You got to take little breaks and just chunk it out into little sections. They'll say, I read the whole chapter for 3 hours. I sit down and I read the entire chapter. And we've all done it. I've done it. I'll sit there and read, right? And if I read for too long, certainly in something very technical, like a EMT textbook, a paramedic textbook, and looking at something very technical, what I found, and I'm sure you guys probably have too, is you'll sit there, and after a certain period of time, you realize that you flipped the pages a few times, and you're not super sure what was on those last few pages, right? You just got this brain fog, this fatigue, and your mind has set in. and you have no idea anymore what you actually talked about. You don't even know what the last paragraph was talking about. You've been reading it, but your brain's not processing anything anymore. You got to take that break, right? So don't just chunk out these huge, big sections, right? It's been shown in tons of just high performance studies and productivity studies that once, 45 to 60 minutes, once you kind of pass that 60-minute mark for sure, then effectiveness and productivity and everything just plummets, right? So take that little break, and again, like a good actual break, right? The getting up, the stretching, the closing your eyes, do some jumping jacks, right? Get that blood moving, right? Because you got to stay energized, right? Energy is a huge thing that you have to manage while you're studying. And so definitely take a break and just do little chunks, right? Little chunks at a time go a very long way. So that's all I got for this one. I hope you enjoyed this session. Again, I so am thankful and appreciative of everybody that's been watching these videos and people have been commenting. It just gives me fuel to keep going. I enjoy it. I've been averaging about 30 hours a week of teaching paramedic classes right now, and these sessions that I'm doing online and seeing people in this setting and everything is just so fun to me. So I can't thank you guys enough for the people that have been watching and watching later, right? Getting the recorded sessions and making sure that you can get the benefits. Hopefully it's helpful on the test taking side of things, certainly helpful on the review of material. And again, thank you. That's all I can say. Thank you very much. And I'll see you next week. Bye.